Hello everyone. As we all know, recently we have got some updates about sepsis management 2026 updates. So it is actually overall of about 88 pages. If we consider the actual part, it will be roughly about 65 to 66 pages. So what we'll do today is we will discuss the updates, but as you can see, there are numerous videos about this update. But according to me, for every medico who is handling sepsis or these infection related cases, not only the updates, they have to know the basic concepts as well. So today, along with updates, we have covered the basic concepts of sepsis. So we'll go through all these things as quickly as possible. So mainly this time it is action oriented. We all know that there are globally around 49 to 50 million cases of sepsis every year, and among that about 30 million deaths will be happening, and this rate is more in middle and low income countries where it might reach up to 60 to 70, 80% of mortality. So the main shift from the previous guidelines to the present one is we should not be approaching the case stepwise. It should be concomitant, like multidisciplinary, synchronized, at a time action should be taken whenever we deal the case of sepsis. We have to know few of the definitions related to sepsis. First of all, what is sepsis? It is a life-threatening organ dysfunction caused by dysregulated host response to infection. So just mere presence of infection will not be considered as sepsis. So any infection which is leading to host response and organ dysfunction, then only we will consider it as sepsis. So what is that organ dysfunction? For that we will utilize SOFA score. Probably we all are familiar with this particular score. So in that one, some 5 to 6 segments or components we will be considering. Among those, if 2 or more components are abnormal, then we consider it as organ dysfunction. Then it will fit into sepsis. This is the first thing. So whenever you get a case of infection, always check for SOFA score. If SOFA score is 2 or more, then you can consider that case as having sepsis. Coming to septic shock, usually in sepsis, we will be giving initial fluid, but after that also, if the individual is requiring vasopressors to maintain mean arterial pressure of more than 65, or if the lactate level is more than 2 millimoles per liter, then we will consider that case is in septic shock. Hope you got understood. So whenever you get the case of sepsis, first calculate mean arterial pressure. Hope you all know the formula for mean arterial pressure. So once if it is less than 65, and you will send serum lactate level meanwhile, if it is more than 2, even after the correction of hypovolemia, that is nothing but the initial fluid, if the individual still persistently having these parameters, we will consider the patient is in septic shock. So the definition should be clear. Mainly to understand the pathophysiology in sepsis, see, we have to know few of the immune related mechanisms in sepsis, because you know that we will be treating with the antimicrobial agents, sometimes immunomodulator therapies. So we have to know when our body's immune system is hyperactive, when it has got paralyzed, and when there is some coagulation related problems, so that the therapy should be always time oriented, in the sense at proper time of the immune mechanisms we have to intervene with proper drugs. That's why if we consider the sequential stages in sepsis, there will be immune hyperstimulation, then there might be immune suppression, along with that there might be coagulation related things like hypercoagulation and hypofibrinolysis. So more of clot formation we will be seeing. So these are some pathophysiological mechanisms which will be happening in sequence with some overlap. So for example, if the individual is in immune suppression stage of sepsis, giving steroids in that particular situation will not help. So if the individual is facing damage due to immune hyperstimulation stage, in that case if we utilize the steroids, then it will serve its purpose. So these are all the mechanisms which we have to always consider, so that we will target with particular drugs at right time. So whenever we are managing sepsis, we have to focus upon these pathophysiology along with some other additional things. For example, cardiovascular management and antimicrobial therapy along with the source control. So these should be our aim. Understand the pathophysiology, focus upon cardiovascular management, antimicrobial therapy and source control. These should be our targets. Then once we got the case as in sepsis, for example, then how we have to proceed. So how to manage? We all know that initially if the mean arterial pressure is less than 65 or lactate is more than 2, we will consider that individual is probably in septic shock. So always we will be giving the first fluid bolus usually of 30 ml per kg body weight if the BMI is less than 30. This is the first important point. Here the thing is, sometimes it is advised that don't follow the universal bolus of 30 ml per kg. Always look for some critical conditions like cardiac disorders and chronic kidney diseases in which we have to utilize the fluid properly by seeing fluid responsiveness. And suppose the BMI is more than 30, the ideal body weight should be considered, and there the initial fluid bolus will change. So this will apply to those who have BMI of less than 30 with no previous cardiac dysfunction or chronic kidney disease. Majority of the times we will be getting such individuals. So it is okay to give about 30 ml per kg of initial fluid bolus. This is the first thing, and it should be started within 1 hour, and this fluid overall, for example, if we consider 50 kg individual, it will come up to 1500, that is 3 pints, should be completed within 3 hours. Then if the individual is not responding to this one as well, then we have to take the help of vasopressors. Ideally, vasopressor of choice is noradrenaline. Don't wait for central line insertion. Start vasopressors from the peripheral line itself. Target for the mean arterial pressure of more than 65. If it is not increasing, we have to place central venous catheter, so that next mode of therapy will be through that one only. Okay, now you have given fluid. The fluid of choice we will discuss later, and the fluid responsiveness. See, it is always the response we have to see whether the individual will respond to our fluid or not. Otherwise, unnecessary load of fluid should not be provided to the individual. Then we will utilize vasopressors first through peripheral line. If it is not improving, we will go with central line. Central line. Even if it is not improving, we have to consider focus, point of care ultrasound, and look for any cardiac dysfunction. Cardiac dysfunction. If cardiac dysfunction is present, we have to utilize the second inotrope as dobutamine to maintain the mean arterial pressure. If there is no obvious cardiac dysfunction, we can choose the second line, that is nothing but vasopressin. Vasopressin as the second drug in maintaining the BP. Even with all these things, if the individual is not improving, we can utilize steroids, mainly hydrocot, 50 mg 4 times IV, overall 200 mg for 1 day. So this should be our line of approach. So every point of time we are seeing mean arterial pressure and we are targeting lactate levels of less than 2. Then I told that it should not be universal fluid supplement. Always first check whether the individual is responding to our fluid or not. So how we should assess it? There are multiple parameters which are being mentioned. For example, pulse pressure variation, stroke volume variation, inferior vena cava IVC, collapsibility we have to check. So that you might be knowing, passive leg rising, and there are some things called as mini fluid challenge and conventional fluid challenge. Overall the point is, first we will check out the baseline parameters. For example, suppose the IVC is 10 mm. 10 mm. So once we give the fluid, initial fluid, right? So after the bolus, if there is change in the IVC diameter by more than 12%, so this threshold is nothing but this much minimum amount of change should be there when we give the fluid. So if this change is there, that indicates the individual is responding to fluid. If this change is not there, we should avoid pushing fluids. That is the overall point of dynamic fluid responsiveness assessment. For example, passive leg raising. See, we have seen cardiac output through focus. Suppose it is, for example, 50. Just for example, I am taking a number 50. So once we give the fluid, there should be 10% threshold, that is change by 10%. So 50 is 10% will be 5, right? 50 is 10% will be 5. So there should be change of cardiac output to 55. This will indicate the individual will respond to fluid therapy. Otherwise, we should stop pushing excessive fluids. Otherwise, sometimes some bedside maneuvers like just mini fluid challenge, so that we can avoid pushing that universal 30 ml per kg of fluid. So in that case, what we will do? Give 100 ml of fluid. Initial cardiac output should be measured. Then look for the change. Suppose there is change by 6%, then the individual will definitely respond nicely to fluids. Otherwise, don't give excess fluids. So this is considered as a good way, because we can avoid excessive fluid load by various other methods. So this is all about fluid responsiveness. So we can utilize IVC collapsibility, we can utilize passive leg raising, we can utilize mini fluid challenge test. We know that in passive leg raise, it is nothing but supplementing about 300 ml of whatever fluid is there in the lower limbs to cardia. So it is nothing but giving extra 300 ml fluid, but it will be reversible. Once the legs are kept in supine position, whatever the fluid we have given by raising it, it will be reversed. So we can avoid unnecessary load from the external sources. Then comes a confusion which fluid to utilize. Remember, balanced crystalloids, for example, ringer lactate, should be the first line of agent, because we can avoid hyperchloremia. Otherwise, in some conditions such as traumatic brain injury, utilize 0.9% saline. What about albumin? Whenever the requirement of fluid is 2 excess for any particular individual, in that case we can choose albumin as well, so that it will hold the fluid in the intravascular compartment. So whoever is already received large volumes of IV fluids, for such individuals, consider albumin as an adjunct. What about some other fluid medias, fluid sources like starches, gelatins? We have to avoid these, because in studies there are clear recommendations against these particular solutions. And important thing is, when it comes to septic shock and utilization of vasopressors, we have to know the dosage and infusion rates properly. So these are all mentioned here. You consider an adult of about 60 kg as ideal. So I would recommend you to calculate this. Consider ideal weight as 60 kg and calculate the dose required for that weight, and always check the vials and dosage or the concentration of drug in the vial which is available in your hospital. So based on that, you have to keep the things ready for noradrenaline, vasopressin, dobutamine. These are very, very important drugs, as I mentioned previously. What about steroids? If the individual is requiring 2 inotropes or vasopressors to maintain BP, but still it is mean arterial pressure is less than 65, in that case we can choose hydrocortisone 50 mg 6 hours, every 6 hours. What about the antibiotic management? See here, the thing is, first you have to follow a protocol which is clearly mentioned here. First, look for any immunocompromised status like HIV positivity or chronic steroid usage, all those things. In that case, you have to discuss with the infectious disease experts for the selection of antimicrobial agents. But otherwise, in other cases, what we have to do is consider the likely bacterial infection and clinical presentation. So, if, for example, there are no risk factors of some virulent organisms, which I will be discussing. So if there is no history of recent hospitalization or residence in nursing home, rehab centers, or frequent visit to hospitals, so all these things, if they are not there, always go ahead with single agent. For example, you can choose ceftriaxone, fluoroquinolone, or some macrolide. Single agent should be started if there are no such high risk factors of virulent organisms. This is the first thing. And we have to know some of the common microbes which will be leading to infections. For example, pneumonia, commonly streptococcus pneumonia. For that, we have to target with particular medication. This is first group we can consider. Suppose there is history of recent hospitalization or regular hospital visits. So in that case, consider nosocomial bacterial pathogens. So always consider antibiotic which will cover MRSAs, Pseudomonas, Klebsiella pneumoniae or Acinetobacter. So in that case, if we are suspecting this possibility, we have to go ahead with broad spectrum antibiotics like broad spectrum cephalosporin like ceftazidime, carbapenems, piperacillin tazobactam. All these things we have to utilize. So this is for the initiation. Always remember to give antibiotic within first hour of presentation, because every 1 hour delay will lead to increase in the mortality by 6%. So go ahead with the antibiotic. Once you are clear about the organism or culture sensitivity report and all, don't hesitate to de-escalate the therapy. This is the overall point. Start antibiotic within first hour of presentation. Okay, then there are some coding system they have advised, and for screening tools, don't utilize QSOFA. Instead of that, some new scores have come, which I will be discussing at the end. Then blood culture, as early as possible we have to send. We know 1 hour bundle of survival sepsis campaign. So always try to send blood cultures before giving the first dose of antibiotics. But suppose there is a delay in sending blood cultures due to any reason, don't postpone giving antibiotics. That is most important. And serial serum lactate we can utilize so that we can check for the responsiveness in tissue perfusion. Then antibiotic timing, as just now I have mentioned. See, suppose there is septic shock, you have to give it immediately within 1 hour. Okay, whether there is definitive evidence of sepsis or possible sepsis doesn't matter. But suppose patient is not in septic shock, and in the sense there is no shock, but there is definite or probable chances of sepsis, administer it. If there is possibility of sepsis but you are in doubt, then we can take some time and we can administer if required within 3 hours. This is the overall point. But what we have seen in numerous cases is within first hour giving antibiotic will be very, very helpful. If you find it that it is not a sepsis, just some other inflammatory condition, you can de-escalate it. No harm in that. Then coming to source control, again we have to like risk of missing pathogen and risk of resistance, we have to balance it. Early source control is very, very important. It is nothing but if you find any drainage like abscess and all, we have to drain it. We have to consider surgical procedures within 6 hours. Then, as I mentioned, you can start with antibiotics, but don't hesitate to de-escalate once you confirm that it is probably inflammation, not sepsis. And for that, we can utilize procalcitonin. I have made a separate detailed video about procalcitonin. One point to mention here is don't utilize this biomarker for the start or escalation of antibiotics. Instead, utilize it for de-escalation of antibiotics. Again, hemodynamic management is very, very important. There are both approaches like liberal fluid giving or restrictive fluid therapy. But overall point is if there are no cardiac or kidney disease risk factors previously, we can go ahead with 30 ml per kg of initial fluid. Then we can tailor it according to the patient's requirement. And one more thing is in fluid responsiveness, if you are in a hurry, you can utilize capillary refilling time as well. Commonly it is utilized in pediatric cases. Then vasopressors, we have discussed properly, first line noradrenaline. Then you can utilize vasopressin. Otherwise, if still mean arterial pressure remains inadequate, then go ahead with epinephrine. Dosage, you have to make the notes and stick it in your ICUs. So the golden hour, like the initially, few things are very important. Initial lactate level and fluid status, basal fluid status should be checked. Send for blood cultures, initiate antibiotics within 1 hour. You can utilize with broad spectrum ones And initial fluid is very important. Complete it within 3 hours. Start peripheral inotropes if BP is low. Vasopressors. Don't wait for central line. Target mean arterial pressure. And always dynamic fluid assessment is very important using some parameters which we have discussed already. So overall, modern standard of sepsis care tells that it should be a parallel approach, not sequential. Then there should be dynamic hemodynamic monitoring utilizing various parameters and maximize utility of antimicrobials when the suspicion is very high, and personalized targets should be done, for example, especially in selection of fluids. Coming to scores, what they have mentioned is Q-SOFA score. It has proven to be lesser efficient in screening. Instead, you can utilize NEWS score, that is National Early Warning Sign score. So in Q-SOFA, we know that 3 parameters we used to check. Here, some 6 are there. If the overall score is more than 5, then we have to properly assess that individual for sepsis. See, these screening tools where you have to utilize it is not in the ICU. If you are seeing a ward patient or HDU patient, in that case, if you feel the individual is not that stable, so then you can calculate these scores. For example, if Q-SOFA, what we used to follow previously, if it is more than 2, suppose you went for rounds in wards or HDU, if the Q-SOFA score is more than 2, that individual require proper care and probably you might need to shift the individual to ICU. This is the utilization. That does not mean that the individual is in sepsis. In the sense, it is not diagnostic, it is just for the screening. Now we have to utilize this parameter. And once sepsis is present, that is, we are thinking of sepsis, then we have to calculate SOFA score. So you have many calculators. You have to know some parameters like respiration related, coagulation related, and LFT, especially bilirubin, and there will be mean arterial pressure, neurological GCS related things, and renal urine output or creatinine. Multiple parameters are there, score ranges from this one, and according to that we can decide the severity of sepsis. Why SIRS, systemic inflammatory response syndrome criteria, is not utilized is because with this there was overdiagnosis of sepsis. So whatever the parameters were there, these will be there even in non-septic individuals, like suppose the individual is in inflammatory state. So there will be overdiagnosis of sepsis and we will end up in giving excessive therapy which is not actually required. So the only drawback was it used to lead to overdiagnosis, like the sensitivity was very high but specificity of finding out the sepsis was very low. So even in some inflammatory conditions, it used to give higher scores. So we used to treat with the usual sepsis protocols. So that was some kind of over treatment. That's why they have stopped utilizing SIRS criteria. So it is only SOFA score, and for screening, new scores like NEWS one. So these are few things about scores related thing. Thank you so much. It was very rapid section, but the overall point is, along with updates, try to learn the basics. Mainly 4 things: fluid, you have to know the dosage, like how much to give and which fluid to give, and look for dynamic response. Then comes utilization of inotropes, vasopressors. Always keep the dosage chart ready in your ICUs or wherever you work. Third thing is antimicrobials. Don't hesitate to start and don't even hesitate to de-escalate when you get the culture sensitivity or procalcitonin levels. Fourth point is utilization of steroids. So these are considered as some kind of 4 pillars of management of sepsis. Hope you got the point. Share it among your friends so that everyone can utilize this new update and the basics of sepsis management.